go like this. Yeah. Sorry. So ocular trauma, as we know, is the 3% of all the emergency presentation and causes almost 1.6 million people blindness in the whole world. And its prevalence is around 2 to 6% of the population, which is really high. And also, whenever we see facial fractures and head injuries, that is likely that the eye is also involved. And what we should do is a detailed clinical examination from anterior to posterior, history taking every detail as much as we can. It's crucial, but because why is it important? Because for the ocular trauma score, if we can do it, we can. That comes the important question: what will we be in the future? So prognosis and counseling, informing the patients and the relatives is an issue in these patients. So we have to be able to do that, but it's not easy because as you can see here, severe patients come in unique ways, different ways, with the severe face traumas, periorbital swelling with pain. Some of them is in pain, suffering. Some of them are unconscious, sedation. So in these conditions, imaging is mandatory. I will be talking about the first 3 to 4 of them but we have a lot of ophthalmology likes technology and vice versa. So we have different modalities improving every year with the imaging. We start with direct X-ray. It is the image is formed according to the characteristics of the penetrance of the ionizing tissue. As you can see here, the hard tissues like bones we can see like white and with bright, and the soft tissues like the muscles and the fat and etc. We see with the tones of gray. It's very cheap and easily available, this technique, but sometimes we can see the metallic foreign bodies. But we cannot localize, that's the point. So it's only can be used as a screening tool, like a fast, if we don't have a special CT for the radio opaque ones. And also we cannot see the other wooden or plastic ones. Also, patient needs some posturing to take these shots because he has to look like face down, touching the eye. There is my timer, okay. And turning to the lateral sides, which is almost very unlikely for the patient to be able to do that in an acute trauma case. Also, it doesn't give any information about the soft tissues, the bones, fractures. It's highly false positive is very high. So it is just in the armamentarium, but actually in the clinical practice, we don't usually use it. So here is a case, as you can see, it's a young man presenting with some foreign body sensation and photophobia in the first day, and he feels like strike object while hammering a metal thing in his car, for example. And with the first, he is sent with the antibiotic eye drops, and coming back in the first week with hypopyon, and we cannot see any foreign body. And direct X-ray, it's the above, as you can see here, direct X-ray, it's very small, but in this case we can detect there's some foreign body metallic, but we cannot localize, although lateral image, etc. But in the CT scan below, you can see that it is located in the anterior chamber, and then this can plan our surgery and the management. So computed tomography first invented in 1963, and which resulted with the Nobel Prize to the Mr. Gomak and Hounsfield, and the unit is named under Hounsfield, the attenuation coefficient of the technical detail. It is the most preferred and primary imaging ocular trauma cases. Why? It's cheap, fast, and safe, and it is easily available nowadays in even almost emergency rooms. It is higher specificity and sensitivity in ocular trauma eyes, no need for posturing of the patients, and suitable for multi-system evaluation with the head, the neck, and everything. So we can do it all together if it is necessary. But there is a disadvantage of using ionizing radiation, which is much higher than a standard chest X-ray. So we usually request for non-contrast CT scans. Orbital CT scans comes like with 3 mm sections, but we should ask, and we should always be in contact with the radiologist, by the way, giving him hints about what we expect in these patients, the clinical situation, if possible, and we ask for thin slices like 1 mm. It's for a better image. Contrast is indicated maybe if we only consider there is a fistula in the cavernous sinus or something like that. So this is about technical data, but we can see that the X-ray photons are sent, and the detectors, the tissue, it passes the tissues, and the detectors measure the change in the intensity. So we can maybe familiar with the Hounsfield unit, with what does it accounts for. Water is 0 because water passes this all together. But if the tissue is less dense than water, it is like negative side, minus. For example, air is minus 1000. But if it is like a bone, hard tissue, it is like plus. So it can be important when we ask for the sections to the radiology. So as you can see in the upper part, it is a tissue. We can also adjust the window width, which is of these Hounsfield units, which means to detect soft tissues better, we should decrease, for example, minus 200 to 200 plus, and then it gives detailed image of the orbital tissues. But look at the bone, they are all white. We cannot delineate anything specific. But if we enlarge it and make it like 1000 to the bone marrow, bone width, as we can see here, for example, the bones look delicate. So we are not also radiologists, but we should be familiar somehow about the optic nerve, and we can have the same language with the radiologist. So here you can see it's the fracture in the bone, lateral orbital wall is seen much better with the bone section. So we should ask, if we are thinking about any fractures, we should ask about axial, coronal, sagittal scanning. Axial, we can, it is like axial scans. We can see the lateral to medial bones and the muscles and everything. But coronal, we can detect superior and inferior better. And sagittal is parallel to the nose, like these sections. So it becomes like a three-dimensional area of the all damaged tissue. And there is a new modern spiral multi-slice CTs, also 3D CT scans, which are actually wanted for extreme like craniofacial surgeries. We can have an orbital 3D image. So this is a coronal section, and this is again the bone width, bone window, let's say. This is a tissue window, so you can see the differences. We should be familiar, I think. So there's a case. It's a high pressure fluid trauma. The case presented like that, but he's like unconscious with pain, and it's like a blunt trauma. But with the CT scans, you can see that is a flat tire image. What is everyone can tell? That is, I can say that the all white, the bones. So this should be tissue image, tissue window, and I can see delineate the structures, the muscles in a better way. But the left eye is asymmetric. It is like a flat tire, lost volume. Anterior chap depth is decreased, and so irregularity in the contour of the posterior. So there is a posterior open globe injury. Likewise, also in this hit by a stone patient, again, is axial tissue and coronal tissue different. We can see, detect the area of the rupture or the open globe trauma. For the metallic foreign bodies, it's the best image, but sometimes if the body is too large, it causes a lot of artifacts. We can talk with the radiologist, they can arrange for a better slide, but sometimes we should get into the OR thinking that it can be in the eye, inside the eye wall, or in the orbita. So sometimes it is because of the artifacts we cannot detect properly. So, I'm sorry. Magnetic resonance imaging. I'll just get into without the details. I'm very sorry. I lost time. So we should always keep in mind this is T1 section, T2 section. The similar T1 weighted images.
1 minute. 2 minutes.
Sorry. One last one. T1 weighted imaging. We can see again the details, as you can see the muscles and everything. And this is T2 for the fluid hemorrhage edema. Can I go?
2 minutes, please. Yes.
Sorry. I cannot work this. Can you, the next slide, please? This doesn't work. The next, okay. So, but MRI, yeah, okay. MRI has advantages with the better contrast, is especially in the soft tissues, especially around optic canal, optic nerve sheath, hematoma, optic nerve area, or the sinuses, cavernous sinus and orbita. It is safe without ionizing radiation. We can repeat as much. But the disadvantages is longer in a closed area, expensive, and that's the one important contraindication. If we any suspect about the metallic foreign body, we must not do this. It can be a malpractice. So it is a case. I go fast. This is the CT scans on the top, and again it's a open globe injury. As you can see, that is the tissue, that is the bone. There is no fracture, but there's a globe perforation. And the MR, we can see even there is no lens. More delineation of the more better resolution, and the area of the rupture, for example. And this is after the reparation, and then comes ultrasound. I'll pass this in a fast way because it is the advantages that every ophthalmologist, I think we should master this technique because it is fast, easy, cheap, and portable. We can do it on the bedside, but of course, if it is a blunt trauma, in the open blood trauma, it's not so easy to. Maybe we can just touch on the lid, but no pressure, without any pressure to the eye. And we should be familiar about the A scan, and we must do with the B scan, always with the A scan imaging, because B scan gives a two-dimensional image, but the A scan gives us the area, the time in between the leg. If there is for example, the spike height and the time, so it gives us the lens is there or not, everything. So B scan, especially for the for the opacities, retinal detachment, vitreous hemorrhage, choroidal detachment. There are some examples. Metallic foreign bodies. I just skip that. Ultrasonic biomicroscopy, just to give. Remember, we don't do it in the clinical, but it gives us a very high resolution, 4-5 millimeter depth of examining the anterior part. Can I move? Can you move?
No.
I will stop, but I cannot control it. That's the problem. Okay, just last slide, please. We should in the armamentary use everything at hand, like anterior segment, OCTs, and photography. Last slide, please. Last slide. Okay, thank you. Thank you.
Thank you, Nur, so much.
Sorry.